కిరణ్ స్టార్ట్ చేసేద్దామా 8:10 అయిపోయింది.
నీకు అది చెప్దాం. 8:10 అయిపోతుంది. స్టార్ట్ చేయాలి. ఇది పెద్ద క్లాస్.
స్టార్ట్ చేసేద్దాం. మెల్లగా జాయిన్ అవుతాను.
ఇది కూడా పెద్ద క్లాసే కదా, స్టార్ట్ చేసేద్దాం.
డన్.
ఓకేనా?
Good morning to all, sir. Sir, am I audible, sir?
Yes, yes.
Okay. Good morning to all, sir. Today we are going to discuss about BPH and the TURP procedure, sir, in detail, sir. The main organ prostate is involved in benign prostatic hypertrophy, and the anatomy of prostate gland is accessory gland of male reproductive system. It is composed of glandular tissue embedded in fibromuscular stroma, and it surrounds first 3 centimeters of the urethra. It is composed of 5 lobes, anterior lobe, posterior lobe, and 2 lateral lobes and a median lobe. Benign prostatic hypertrophy involves median and lateral lobes. Usually primary carcinoma is involved. Posterior lobe involves the primary carcinoma, and McNeil divided prostate into 3 zones, in which the peripheral zone is mostly prone to carcinoma, and periurethral transition zone is prone to benign prostatic hypertrophy, and there is also central zone. The anatomy of prostate. This is a schematic diagram showing the anatomy of prostatic gland. It surrounds the first 3 centimeters of the urethra. And the seminal vesicles open through this prostate gland into the urethra. And these are the lobes of the prostatic gland. In cross-section view, the lobes, and there are 2 lateral lobes and 1 anterior lobe, and 1 median lobe and the posterior lobe. This is another view with color differentiation of the lobes. Anatomy of prostate. The prostate nerve supply is, it has sympathetic and parasympathetic nerve supply, and sympathetic nerve supply is from T11 to L2 and inferior hypogastric plexus, and parasympathetic supply is from sacral 2, 3, 4 segments and pelvic splanchnic nerve. The arterial supply is inferior vesical artery, middle rectal artery, and internal pudendal artery, and the venous supply is through vesical plexus, internal pudendal veins, and vertebral venous plexus. Benign prostatic hyperplasia or benign prostatic hypertrophy. This is the normal prostate, normal in size prostate. When the benign prostatic hypertrophy occurs, the lateral lobes are generally involved, and they increase in size, compressing the urethral passage, which causes obstruction to the passage of the urine. Non-cancerous increase in size of prostatic gland, which involves hyperplasia of prostatic stroma and epithelial cells, resulting in the formation of large, fairly discrete nodules in transitional zone of prostate. This increased tissue occupies more space, and this pushes and narrows the urethra, resulting in an increased resistance to flow of the urine from the bladder. The clinical manifestations of this hypertrophy, benign prostatic hypertrophy, are hesitancy in starting urination, increased frequency of urination, nocturia, urgency during micturition, and abdominal straining. Decrease in volume and force of urinary stream, interruption of urinary stream, and dribbling of urine, sensation of incomplete emptying of the bladder, acute urinary retention. The urine generally remains incomplete maturation occurs, leaving more than 60 ml of urine in the bladder. Recurrent UTIs occurs, fatigue, anorexia, nausea and vomiting, pelvic discomfort and pain. These are some of these are the symptoms, and ultimately it leads to azotemia. Renal failure result in chronic urinary retention and large residual volumes. All the pharmacological management of this BPH is alpha blockers. These medications relax bladder neck muscles and muscle fibers in the prostate, making urination easier. Alpha blockers generally include what we use generally include alfuzosin, doxazosin, tamsulosin, and silodosin. Usually work quickly in men with relatively small prostates. The other type of drugs we use are 5-alpha reductase inhibitors. These medications shrink prostate by preventing hormonal changes that causes prostate growth. These medications, 5-alpha reductase inhibitors, these include finasteride and dutasteride. It may take 6 months or more to show the effect of these drugs. After medical management, the other management is surgical management. In surgical management, there are two types of surgeries: minimally invasive therapy and invasive therapy. In minimally invasive therapy, the procedures are transurethral microwave thermotherapy, transurethral needle ablation, laser prostatectomy, photovaporization, interstitial laser coagulation, and intraprostatic urethral stents. These are the microinvasive surgeries, minimally invasive procedures generally followed in BPH. And the other method is invasive therapy. That is, invasive treatment of symptomatic BPH involves surgery. The choice of treatment approach depends on the size and location of the prostate enlargement and the patient factors such as age and surgical risk. The TURP, I mean transurethral resection of the prostate. Transurethral resection of the prostate is a surgical procedure involving the removal of prostate tissue using a resectoscope inserted through the urethra. This is prostate and this is the resectoscope which is inserted through the urethra. The resection of enlarged prostate tissue is done through this method. TURP procedure performed in the lithotomy position using a resectoscope through which the diathermy loop is passed. The prostatic tissue is resected in small strips under direct vision. The bladder is continuously irrigated with fluid. At the end of the procedure, a through lumen catheter is inserted and irrigation is continued for up to 24 hours after operation. The procedure usually takes 30 to 90 minutes. The irrigation fluids, the uses of irrigation fluid, it distends the bladder and prostatic urethra, flushes out the blood and tissue debris that occurs during resection, and improves visibility. The characteristics of ideal irrigation fluid that we must use is it should be transparent, it should be isotonic, electrically inert, non-hemolytic, inexpensive, non-metabolizable, rapidly excretable, non-toxic, and easy to sterilize. The different types of solutions that can be used as irrigation fluid are mannitol, sorbitol, glucose, urea, and cytol. The advantage of mannitol is it is isomolar solution and cannot be metabolized. And disadvantages are it causes osmotic diuresis, acute intravascular expansion. Sorbitol is almost similar to glycine, but the disadvantages are hyperglycemia, lactic acidosis, and osmotic diuresis. Glucose, it causes hyperglycemia, and urea 1% increases blood urea. Cytol is expensive and not easily available. The other fluids, irrigation fluids, are distilled water. The advantage of distilled water is it is electrically inert, improved visibility, and inexpensive. But disadvantages are it can cause hemolysis, hemoglobinuria, hemoglobinemia, and hyponatremia. The other fluid is glycine 1.5% and glycine 1.2%. Glycine 1.5% is isomolar with body fluids and less like it. The advantage is it's less likelihood of TURP syndrome. And disadvantage is transient postoperative visual syndrome can occur, hyperammonemia and hyperoxaluria can occur. Normal saline 0.9%. It can be, it is isomolar with body fluids. It is also less incidence of TURP syndrome. But the disadvantage is it is ionized and cannot be used with cautery. It can conduct electricity. Ringer lactate, it is also isomolar with the body fluids, but it is also ionized and cannot be used with cautery. The factors affecting amount and rate of fluid absorption is the size of the gland, number and size of the sinuses that are open, and hydrostatic pressure of the irrigation fluid, duration of procedure, and integrity of capsule, venous pressure at irrigant blood interface, and vascularity of the diseased prostate. Preoperative considerations in the patients that are posted for the TURP surgery are: patients for TURP are frequently elderly and with coexistent diseases. Cardiac disease generally involved with the diseases that are generally involved with these patients are cardiac disease in almost 67%, cardiovascular disease 50%, abnormal ECG in 77% of the patients that are posted for this surgery, chronic obstructive pulmonary disease 29%, diabetes mellitus 8%. Occasionally, patients are dehydrated and depleted of essential electrolytes. Due to long-term diuretic therapy, they may be using for the other comorbidities. Long-standing urinary obstruction can lead to impaired renal function, chronic urinary infection. About 30% of TURP patients have infected urine preoperatively. The preoperative evaluation of these patients, the assessment and examination of all the organ systems should be done. Investigations like hemoglobin, total leukocyte count, differential leukocyte count, platelet count, blood sugar, blood urea, and serum creatinine, serum electrolytes, urine routine microscopy, and ECG, chest X-ray, and blood grouping and other cross-matching should be done. Preoperative preparation. Optimization of pre-existing comorbid conditions is important in these elderly people, and consideration of ongoing drug therapy. Antibiotic prophylaxis in case of urinary tract infection or urinary obstruction, and arrangement of blood, if at all requirement may be present. The choice of anesthesia. Nasal anesthesia is technique of choice for TURP. Advantage of nasal anesthesia or general anesthesia is allowing monitoring of mental status and early signs of TURP syndrome and bladder perforation, and promotes peripheral vasodilatation, reducing circulatory overload, reduces blood loss requiring fewer transfusions, avoids effect of general anesthesia in pulmonary pathology patients. Good early postoperative analgesia, reduced incidence of postoperative DVT, neuroendocrine and DVT and pulmonary embolism also. Neuroendocrine and immune response are better preserved and comparatively less cost with nasal anesthesia. General anesthesia preferred when nasal anesthesia is contraindicated. The techniques we generally follow in nasal anesthesia for these patients are subarachnoid block, epidural block, caudal block, or saddle block. Level of sensitive block should be, if it is at the T10 dermatum level, it eliminates the discomfort caused by bladder distension. And if if the level is at T9 dermatum level, it enables to elicit the capsular sign, that is pain that occurs when the perforation of the capsule is done, prostatic capsule is done. Subarachnoid block is generally preferred because advantage of subarachnoid block over epidural anesthesia is technically easier to perform. In subarachnoid block, there is dense motor blockade and no sacral sparing is present, and lower incidence of PDPH. The monitoring that should be done in these patients are ECG monitoring should be done, blood pressure monitoring, and pulse oximetry, I mean saturation of the patient, temperature of the patient, mentation, the mental status of the patient, whether the patient is conscious or irritable, and the blood loss that occurs due to surgical procedure, and serum electrolytes. The serum electrolytes should be serially done for every 50 to 20 minutes, and ETCO2 if general anesthesia is used. Intraoperative considerations are lithotomy position should be present. The patient should be placed in lithotomy position, and we should take care of the TURP syndrome that can occur due to during the surgical procedure, and bladder perforation it should be taken care of, and hypothermia. Hypothermia, the patient should be protected from hypothermia. Transient bacterial septicemia can also occur, and hemorrhage and coagulopathy it should be also considered. In lithotomy position, both the lower limbs raised together, flexing the hips and knees simultaneously. Ensure proper padding at the edges and angulations to reduce the impact injuries. And while lowering the legs should be brought together at knees and then lowered slowly to prevent stress on spine and sudden fall in BP. The physiological changes with lithotomy position, it decreases FRC and increased venous return on elevation of legs, and decreased venous return following lowering of legs, exaggeration of hypotension with subarachnoid space block, spinal anesthesia. Problems with lithotomy position. These are the physiological changes that occurs when the patient is positioned in lithotomy position. Problems with lithotomy position are injury to nerves can occur if there's no proper padding and protection is not given to the patient, and injury to fingers, compression of major vessels at joints, and lower extremity compartment syndrome can occur. Aggravation of pre-existing lower back pain can occur in patients. TURP syndrome generally occurs due to rapid absorption of large volume of irrigation solution. It can occur 15 minutes after resection or up to 24 hours after postoperative period. The incidence is 1 to 8% and characterized by intravascular volume shifts and plasma solute concentration effects. It causes circulatory overload. TURP syndrome causes circulatory overload, water intoxication, hyponatremia, hypoosmolality, hyperglycemia, hyperammonemia, and hemolysis. This is a schematic diagram that shows how the mechanism of the TURP syndrome is present. The TURP syndrome risks are open prostatic sinuses. The more the number of sinuses open, the more the patient is prone for TURP syndrome, and high irrigation pressure. The high pressure that of the irrigation fluid that are being used. So the height of the irrigation fluid should be maintained at almost 60 centimeters from the operating table. The more the height, the increased pressure of the irrigation fluid occurs. And lengthy resection. The surgical resection duration should be managed and should be decreased. And ideally, it should be done within 60 minutes, which reduces the percentage of chances of the TURP syndrome. And the irrigation fluids we use, the more hypotonic irrigants we use, the more chance of TURP syndrome. And if the open sinus is open, the irrigation fluid is absorbed, and it increases the volume of the circulating blood. Circulating overload occurs due to increased blood volume. It causes hypervolemia, and this hypervolemia may lead to cardiac overload, and left ventricular failure can occur, and it causes cardiovascular collapse ultimately. And this left ventricular failure can also lead to pulmonary edema, which causes respiratory failure, which ultimately leads to cardiovascular collapse. This hypervolemia may lead to hypertension and bradycardia. And the other method And this is volume increase, and the solute changes also occurs due to increased absorption of the irrigation fluid. The solute changes, it causes hyponatremia. The solute concentration of sodium decreases, and it causes hyponatremia, which leads to hypoosmolality. This hypoosmolality leads to hemolysis, pulmonary edema, and also cerebral edema. This pulmonary edema leads to respiratory failure and cardiovascular collapse in this hypoosmolality prolongs, and hemolysis occurs, which leads to acute renal failure. And the cerebral edema causes visual changes, which causes transient blindness, and also it causes encephalopathy. This occurs due to dilutional hyponatremia. And the solute concentration of glycine, the glycine increases in blood, which causes increase in glycine and increase in ammonia, which glycine metabolizes to ammonia. And this causes ammonia encephalopathy, and glycine causes visual transient visual loss. The TURP syndrome or water intoxication syndrome, it causes cerebral edema. Signs and symptoms: the patient becomes restless, seizures can occur, and patient can ultimately land in coma. Central nervous system decerebrate posture and clonus seizures can occur. Positive Babinski's reflex is present. Eyes in eyes, the papilledema can occur due to cerebral edema, and dilated and non-reactive pupils may be present. EEG, low voltage complex is seen in EEG. The manifestations of hyponatremia: if the serum sodium level is 120 milliequivalents per liter, the CNS changes are generally confusion and restlessness, and cardiovascular changes are hypotension, bradycardia. ECG shows wide QRS complexes and bradycardia. If the serum sodium level is 115 milliequivalents per liter, the patient becomes nauseatic and somnolence occurs. It causes cardiac depression, cardiovascular changes, and bradycardia, wide QRS complex, and elevated SD segment changes can also be seen in ECG. And if the serum sodium level is further less, and it is 110 milliequivalents per liter, the patient can present with seizures and coma, and cardiovascular changes occurs that can occur are congestive heart failure, and ventricular tachycardia or fibrillation can be seen in ECG. TURP syndrome hyperglycemia. Glycine is a non-essential amino acid and is an inhibitory neurotransmitter in spinal cord and retina. It is metabolized by liver by oxidative deamination and ammonia, and separated into ammonia and glyoxylic acid, which leads to formation of oxalic acid. When absorbed in large amounts, it has direct toxic effects on heart and retina. Manifestations of glycine toxicity is nausea, headache, malaise, weakness, visual disturbances. The blindness is transient, and seizures and encephalopathy. The TURP syndrome hyperammonemia. Excessive absorption of glycine may lead to hyperammonemia. That is, the ammonia levels are greater than 500 millimoles per liter. The signs and symptoms are nausea, vomiting. The patient may be comatose for 10 to 12 hours and awakens when the blood levels of the ammonia decreases to 150 millimoles per liter. This is the cycle. This glycine metabolized by the liver into ammonia and glyoxylic acid, and glyoxylic acid forms oxalic acid, and this ammonia combines with carbon phosphatase, aspartic acid, and forms citrulline. And in this process, arginine converts this complex into urea and ornithine. If this arginine deficiency is there, that it cannot be converted into urea, and the ammonia, the cycle cannot take place, which hinders this cycle and causes increase in ammonia content in the blood, which causes hyperammonemia. There are different systems involved in TURP syndrome are neurological system, cardiovascular system, respiratory system, hematological system, renal system, and metabolic system. And the neurological symptoms that can be seen in TURP syndrome are nausea, restlessness, transient visual visual disturbances, confusion, somnolence, seizures, and coma. And the main cause for this neurological symptoms that are occurring in TURP are TURP surgery are hyponatremia and hypoosmolality, hyperglycemia, and hyperammonemia. Cardiovascular system. In cardiovascular system, the signs and symptoms are hypertension, reflux bradycardia, pulmonary edema, cardiovascular collapse. Hypotension can also occur. ECG changes are generally wide QRS complex, elevated acidic segments, and ventricular arrhythmias. The cause is rapid fluid absorption and third space hyponatremia. The respiratory system is also involved in TURP syndrome, and the signs and symptoms are generally tachypnea, oxygen desaturation, and change to pattern of breathing is present. The cause is pulmonary edema. And hematological system, disseminated intravascular coagulation can occur in severe cases, and hyponatremia and hypoosmolality is the main cause for this DS, I mean disseminated intravascular coagulation, hemolysis. Renal failure can also occur due to hypotension or hemolysis or hyperoxaluria. Metabolic acidosis occurs due to deamination of glycine. The measurement of fluid absorption. Volume absorbed is equal to preoperative sodium by postoperative sodium. That is preoperative sodium divided by postoperative sodium ECF. I mean, volume absorbed can be calculated by preoperative sodium concentration in ECF minus postoperative sodium concentration in ECF. Volumetric fluid balance, difference between amount of irrigation fluid used and the volume recovered. It gives the amount of volume that remained in the blood circulation. And gravimetry measures rise in the body weight. Okay, CVP monitoring is another measurement of fluid absorption, and breath ethanol measurement and isotopes. These are other methods. The TURP syndrome prevention, early diagnosis and prompt treatment of the syndrome, and correction of fluid and electrolyte abnormalities preoperatively, cautious administration of IV fluids, the limitation of hydrostatic pressure of the irrigation fluid to 60 centimeters to the surface, operating surface, and restrict duration of TURP, I mean transurethral resection prostate surgery to 1 hour, and bipolar resectoscope. Then the using of bipolar resectoscope decreases the number of sinuses that are opened, and it also prevents the TURP syndrome. And vaporization methods and local vasoconstrictors. In TURP syndrome management, the surgeon should be immediately notified, and the surgery should be terminated, and ensure oxygenation of the patient, restrict the fluid that are given to the patient, and pulmonary edema. In case of pulmonary edema, intubate and intubate the patient immediately. And bradycardia, hypotension in patients with bradycardia and hypotension, atropine and adrenergic agents can be should be given. And in seizures, benzodiazepines and thiopentone or phenytoin. In some patients, IV magnesium can also be given. Invasive monitoring of arterial and CVP. Send blood samples for electrolytes, arterial blood gas analysis. TURP syndrome management. Treat mild symptoms. If sodium concentration is greater than, serum sodium concentration is greater than 120 milliequivalents per liter with fluid restriction and loop diuretics, mild symptoms can be given treated with using just loop diuretics like furosemide. In case of severe symptoms, that is, if serum sodium level is less than 120 milliequivalents with 3%, The treatment should be given with 3% NaCl IV at rate of less than 100 ml per hour. In cases of bladder perforation, the incidence of this bladder perforation is 1%, and the causes cause of bladder perforation are trauma by surgical instruments or overdistension of the bladder with irrigation fluid. The early sign of this bladder perforation is sudden decrease in return of irrigation solution from bladder, and extraperitoneal perforations, pain in periumbilical, inguinal, or suprapubic regions. Intraperitoneal, generalized abdominal pain, shoulder tip pain, abdominal rigidity. These can be also seen in intraperitoneal fluid accumulation. The blood loss should be assessed in these patients. Difficulty to quantify. It is difficult to quantify blood loss. Visual estimation of hemorrhage may be difficult due to dilution with irrigation fluid. Usual warning signs are tachycardia and hypotension. It is masked by overhydration and effects of regional anesthesia. Generally, blood loss can be estimated on the basis of resection time. That is, on an average, the blood loss is 2 to 5 ml per minute, and the size of prostate 7 to 20 ml per gram. Number of open sinuses, and intraoperative intraoperative should be based on preoperative hemoglobin. Intraoperative blood test should be based on preoperative hemoglobin, duration and difficulty of resection, and clinical assessment of patient condition. Coagulopathy, cause of excessive bleeding, dilution of thrombocytopenia, and disseminated intravascular coagulation as a result of release of prostatic particles rich in thromboplastin into blood, and local release of fibrinolytic agents like plasminogen and urokinase. Treatment is administration of fresh frozen plasma, platelets, and blood transfusion. Hypothermia, continuous fluid irrigation causes loss of temperature at the rate of 1 degree centigrade per hour. Elderly patients have reduced thermoregulatory capacity. Unintentional hypothermia is associated with significantly higher incidence of postoperative MI. So postoperative MI, shivering associated with hypothermia may dislodge clots and promote postoperative bleeding. The patient body temperature should be monitored to maintain normothermia, and appropriate measures to reduce heat loss are warming blankets, heat irrigation solution, and warm IV fluids. Bacterium and septicemia. The incidence of bacterium and septicemia is 67%, and the causes are generally release of bacteria from prostatic tissue, preoperative indwelling of urinary catheter, and preoperative UTI. Clinical features are chills, fever, and tachycardia, and treatment is antibiotic and supportive care. Postoperative complications: hypothermia, hypotension, hemorrhage, septicemia, the TURP syndrome, and bladder spasm, clot retention, deep vein thrombosis, postoperative cognitive impairment are the postoperative complications. Thank you, sir. Hello, sir.
Hello, Jagadish.
Hello, sir. Hello, sir. Okay, sir. Thank you so much, sir.
Hello, good morning.
Good morning, sir.
How do you classify prostate enlargement based on ultrasound?
Based on ultrasound, sir. I have no idea.
How many grades are there? What is the normal weight of prostate?
Around 60 grams, sir.
30 grams.
30 grams. Okay, sir.
Four grades are there.
4 grades, sir. Okay, sir.
What is the surgical indication depending upon the post-vital residual urine? When it is greater than?
When it is greater than 60 ml, sir.
60 or 100? Huh?
Actually, and it's 67 mostly. I will confirm, sir.
Apart from TURP, what are the other approaches for prostatic surgery?
Sir, minimally invasive procedures are there, sir. That is
not minimal invasive. Open. There are other approaches. Suprapubic approach.
Okay, sir. Sir, open surgery, sir.
No, open surgery.
Okay, sir. Okay, sir.
What happens if you correct hyponatremia rapidly?
It can lead to point-end demyelination syndrome, sir.
Better diagnostic procedure than ultrasound for prostate enlargement for confirmation.
Better than ultrasound, sir.
Yes.
Sir, is it MRI, sir?
Yes. Gadolinium contrast MRI. So at the end of the surgery, you will put a 3-way Foley's catheter.
Yes, sir.
So how much amount of the distilled water should be given for that to bulb, Foley's bulb, 3-way catheter?
Sir, 10 to 20 ml, sir.
No, 10 to 15 is normal Foley, single way we usually use.
Okay,
this
sir.
is 3-way for irrigation. You have to give 40 to 50.
40 to 50 ml, sir.
Yes.
Okay, sir. Okay.
Did you observe any perforation, intraoperative perforation? Any
No,
experience?
sir. No, sir.
Recently, I had an experience. After cystoscopy, there was he was not able to pass urine and blood was coming.
Okay, sir.
So they want to re-explore. The patient was given initially ketamine because he underwent laminectomy.
Okay,
The
sir.
previous duty, they have given done cystoscopy under ketamine. As soon as I started my shift, they posted the case for re-exploration.
Okay, sir.
Because they thought that it is a clots are there. We want to irrigate the bladder.
Okay, sir.
Patient was stable, so I gave spinal.
Okay, sir.
After giving spinal, the blood pressure crashed to 30. I rushed the fluids and given a symptomatic amines, mephentrine.
Okay, sir.
Patient went into altered sensorium transiently. Then immediately intubated the patient.
Okay, sir.
And there was a gradual distension of the abdomen. The surgeon asked me to aspirate, take a 10 cc syringe and aspirate on the lateral flank. I aspirated. There was a fluid was coming, irrigating fluid.
Okay,
So they opened and done a urinary bladder repair, and patient was kept on ventilator. Next day, extubated. Irrigation was continued for 72 hours.
Okay, sir. Okay.
Postoperatively, what is the fluid used for irrigation? During surgery, you use
Glycine, sir.
glycine.
Yes, sir.
Yes, at the end of the surgery, what you will use?
Normal saline, sir.
Yes, normal saline. How many hours you should continue irrigation?
Up to 24 hours, sir.
Yes, good. How do you manage bleeding?
Sir, I mean, assessment of blood loss, sir, or bleeding?
No, patient with irrigating fluid is going on.
Yes,
Return
sir.
fluid is red. So what will you do? You will increase the speed of irrigating fluid. And when the return fluid becomes light, you will decrease the speed.
Okay, sir.
These are the practical points. Nobody will teach us unless you do some ICU duties.
Okay, sir. Thank you, sir. Thank you.
Thank you.
Thank you, sir.
4 o'clock office.